But the main thing for me was to give patients health literacy and agency. So it wasn't trying to catch murderers. That wasn't the reason I was doing it.
Hi, I'm Caitlin.
And I'm Clarinda, and this is Not Just Patients,
a podcast where we break barriers to meaningful patient involvement in healthcare.
Thank you for tuning in to this episode today. Today we're going to be speaking to Dr. Richard Fitton about empowering patients through access to their electronic health records.
Richard Fitton is a retired general practitioner. He undertook an NHS electronic record development and implementation pilot project in 2001 on patient access records. He worked with WellMed Record in the USA in 1999 to 2001, presented at the ICMCC conferences in 2006, 7 and 8. He worked with the Department of Health on copying letters to patients working group, with the Wellcome Trust working group on the secondary use of GP data for research, National Care Record Development Board, UK GMC production team for the first guidance on sharing records with patients in 2007. He has also consulted with UNESCO on the use of human genetic data, presented at the WHO FIC, WHO Patient Safety Conference in Geneva, at the international conferences on urban health in Nairobi, New York, Baltimore and Manchester, St. Petersburg House of Commons and House of Lords, and at the UN World Data Forum in China. Thanks so much for joining us today.
Thank you very much for inviting me to talk to Not Just Patients, which I think is a really great initiative.
Thank you so much. And also an extra kind of fun personal angle that we have on this one. So it would be weird for me not to mention, I think, that this interview with you came about. So I was actually working from home a few weeks ago at my parents' table, and who comes to the door but Dr. Fitton. And we're usually on a first name basis on this podcast, but I find it really strange not calling you Dr. Fitton because Dr. Fitton is a household name in my house. So you were my GP, general practitioner, the child, in the general practitioner's surgery across the road. And what's really kind of nice, and I've spoken to this on the podcast before, is that my experience sort of growing up with a rare disease was very privileged for many, many reasons. But one of those reasons was I just had some really great and helpful practitioners growing up who supported me and my parents, especially. One of those people being you, Dr. Fitton, and we talk about it all the time at home about how much you supported with providing me care locally at home and the training that you got so that you could help my parents with that, so we didn't have to go to the hospital so much when I was a child. And then as well, so you knocked on the door and shared this article on electronic health records, which I then read and sort of started to read up about all the fantastic work you're doing, and it was really aligned with what we're doing at Not Just Patients. And also, and we'll touch on this later, you know, you actually worked with my dad on electronic health records, who I didn't even know was involved in health in any way at all. So it's all very weird and serendipitous, but really nice. And I'm so glad we can have you on the podcast.
Yeah, that's lovely. Thank you.
So we can get started with the interview now. So firstly, to set the scene, we're going to be talking about electronic health records today. Could you define what we mean by that and what it includes?
Yes, I have made some notes which I'm going to use, but if you want to interrupt me, please do so. Electronic records are digital health, I'm going to call them machines, which process and store patients' personal health data as the patient receives healthcare. They store, update, and maintain the patient's name, age, sex, gender, address, phone number, next of kin details in hospitals, and other contact details. They produce communications to patients, they create discharge letters, they store bedside observations, they create prescriptions, they are used for billing and audit, they're useful for medical legal defense when things go wrong, and they always will go wrong, and they have other functions. The records belong to the service providers and to the healthcare professionals who process the patient's data. Healthcare professionals generally process patients and patients' data simultaneously. By that I mean, as they're treating people, they're making records at the same time or in a very short period of time afterwards. Patients' personal health records build up over time and come to act as a digital representation of the patient, almost I would call a patient avatar, if you like. It's a representation of Caitlin or Clarinda.
Right.
The records include the notes, considerations, and thoughts of the healthcare professionals. They act as aid memoirs and they are requisite for medical legal purposes. Doctors couldn't practice without these to defend themselves when things do go wrong. For audit, for research, and follow-up of clinical interventions. So as somebody is prescribed a clinical intervention which might last for 50 or 60 years, the notes will help gain some sort of idea of the progress or lack of progress. The records contain large amounts of health data which patients should have access to and should have copies of. So that's my answer to setting the scene for what we mean by electronic health records. Actually, there is one little bit more, which is pretty complicated, but I think it's very, very important in this juncture in the next 5 years with digital medicine. So I think that the terms we're going to use requires some clarification as we examine the empowerment of patients through access to their health records. Data are facts and statistics collected for reference or analysis. Information, and I'm sorry to be pedantic about this, but I think it's really important, is data presented in a way that can be comprehended. Knowledge is the product of two or more pieces of information or data with reference to one piece of data. Understanding is the product of the application of two or more bits of knowledge to a piece of data or information. So you will both have an understanding of your disease and your investigations, which will be different to the doctor's and it'll be different to everybody else's. And it'll be mainly right, it'll be slightly wrong. But that is what an understanding is, and it changes. So that's understanding. Wisdom, once again, which isn't always right, is the product of observing the repeated effects of application of knowledge and understanding to data. You will be both very wise, as you've said in your podcast about yourself and about your conditions, and often wiser than the clinicians, nurses that you see. Not everybody's like that. And my journey really was to try and help patients get to be more wise and to be able to advocate for themselves. Intelligence is the capacity for abstraction, logic, understanding, self-awareness, learning, emotional knowledge, and reasoning. Critical thinking is the process of analyzing available facts, evidence, observations, and arguments to make sound conclusions or informed choices. Now, that's all really wordy, weighty stuff, but in a way, it's what I've been trying to do for 30, 40 years. And when I built the medical center, I didn't even know what I was doing, but I just thought, I want to get people to think more critically, to be wiser about themselves. I don't see how they can do that if they don't even have their own data and they don't have their own records. Health literacy, and once again, I've quoted this from somewhere, is the ability to find, understand, and use health information and services to make informed health-related decisions, and then to have the agency, which is the ability to act and respond to the data, information, knowledge, understanding, and wisdom. And as we'll probably say as we go through, the old-fashioned, understandable, paternalistic culture of general practice didn't suit me 30 years ago. I thought, these patients are not going to get better unless I try and give them the data, give them the critical faculty to think about things.
So that's really, really interesting. Thank you, Richard, for setting the scene there. And I really love how you built that whole story from data to health literacy. I think that contextualizes things so well because where I'm coming from, when I was discussing this whole topic with Caitlin, it was a big conundrum for me because honestly, I feel like from the India perspective, it's a very complex topic for me to speak about. Because like you said, you made the decision 30, 40 years ago to change the paternalistic approach. That approach is still very much predominant in healthcare in India. Health literacy is still very much backward, you could say, in India. It's far from where it should be. Patient records, electronic records are a small percentage of the way health data is captured, in India. And that's probably in big cities, in facilities where there is internet access, computers, and all of that, which is again a very small percentage of the entire ecosystem in India. So, I can almost feel like how much of this applies to me or to my country or my population, because most doctors here would still be writing on the paper. And those are important records, of course, but those leave with the patient. And I had posted one picture on LinkedIn, I remember, which had all my files from all my different medical specializations and I have so many comorbidities. So I have like files for neuro and ortho and various things. And they filled up my whole dining table essentially. And I
Yeah.
have them all categorized. But basically, I have 15 years worth of files
Yeah.
lying
Yeah.
around that I need to figure out what I am taking to which consultant and
Brilliant.
or that I am
Mm.
maintaining my records. Not all patients are necessarily doing that. And of course, the burden lies with the patient here. But it still gives me a lot of hope that it took you as one single practitioner in a general practice to have that change of mindset and say that this is something I want to start doing. And then now you're taking that to a global scale with the work that you're doing. It makes me feel like, that revolution can start in a small way. It just takes one person and
Yeah.
then that snowballs and all
Yeah.
of that. And that's again something that we have spoken about before. So it feels like we might be some way off. It's not necessarily something that's not imminent. It's going to happen and I can be there when that's happening. And that's quite reassuring to know. I'd love to know more about your story and how you came to be so interested in this topic and what made you feel like you were not in the right setting when you decided to make that shift.
Well, just before we go on, congratulations with what you do. And you've actually illustrated beautifully to me what the whole thing is about. It's about you or us, doctors and patients together, keeping on top of all the very complicated sets of problems sometimes. And it is possible with paper. Funnily enough, I have actually got a folder of my own medical records and scans. I've been very lucky with my health, but I've got slight osteopenia. I've got a bit of a trouble at the bottom of my esophagus. I shout at the consultants and I say, can I have copies of the pictures of the x-rays? So I've got my dental records because you can't do it digitally. This will happen for the next 100 years. So to some extent, it's lovely that you're doing that. So Clarinda, yes, you're asking about my story. In September 2023, I was asked to moderate the World Health Organization working group that drafted the 8th patient right of the WHO Patient Safety Charter, the right for the patient to access their records. And the reason they asked me was because I and a group of patients and colleagues had been having conversations with World Health Organization about patient access to records for many years, almost 2 decades. Why was I interested? Before going to study medicine at university in 1969, my father, a very brilliant orthopedic surgeon, arranged for me to work with a computer-aided diagnosis and digital patient records research at Leeds University. He was very clever, my dad, and he could see it was very interesting. I spent 6 months using a computer language called ALGOL, which you won't have heard of, to create digital artificial patients, all that time ago. And this, of course, helped me when I was talking to your dad, Glenn. He knew about this sort of stuff when I met him. You know what he's like.
So my dad, just for people listening, he's not involved really in health at all, but he's a software engineer. So that's why he kind of understands this whole.
Well, we wouldn't have got where we were in the practice with records, and the country wouldn't without Glenn's work. I learned to use Lawrence Weed's problem-orientated medical records while at medical school in London, and I qualified in 1974. These were really important because it teaches you to actually try and paint a bit of a picture, a quick snapshot of the patient. So as the patient goes through the system, they have cystic fibrosis, they've got this problem with their lungs, whatever. And it's to help you think a little bit more holistically, clinically, but holistically. In fact, as I went on in general practice, I started doing social summaries as well. That was really useful because I used to find somebody keep coming in, you think, I'm not getting anywhere here. So I used to stop. I think, right, I'll ask them what football team they support. What's the name of your dog? What sort of food you like? You just change the subject a bit. So it's really useful trying to get a picture of a person, not just the medical stuff, but them as a person, their family, who they are, what they are. I trained to be a general practitioner and I did obstetrics, pediatrics, infectious diseases, rheumatology, orthopedic surgery, all sorts over 5 years, which makes you realize that doctors aren't talking to each other. We keep recording the same data, but hide it away in a silo. I met my wife, who has got an anthropology degree, a master's degree in information science and librarianship, and a master's degree in the political effects of religious pluralism in Brazil. Very clever and very, very good on information science and on anthropology. And actually, when I look at this, I think, wow, how much of this has come from my wife? Although she hates me talking about it. But it's because she was an information scientist and she was just beginning to use online medical searches from America in the 1980s. So anyhow, Georgia General Practice in Manchester. When I got there, I summarized all the practice's paper records. My wife helped me at home and created a card index list of patients with major diseases. It wasn't there. You just had a set of notes and you didn't know who anybody was at all. So the computer's great for that. So you begin to know who all the patients are with cystic fibrosis, diabetes, whatever. And you can think, well, should we be doing anything else for them? If you don't have the list, you can't do it. If you don't have a summary card, you can't do it. So it was a lot to do. And so eventually we started installing these onto our first computer in 1985, which was
Fascinating.
the patients in my practice is an inner city practice. I wanted to work in an inner city practice, which had problems with deprivation after the Black report and the Aitchison report had shown the discrepancy of outcomes in different parts of the country. Our patients had a lower life expectancy than patients who live just 6 miles down the road in Denton as opposed to West Scotland. And I wondered if a computer and shared patient-held records could improve patients' health literacy and agency, as well as improving clinician-led patient outcomes. So committed to this idea, I moved to take over a small single-handed practice. My partners weren't interested. I'm still very good friends with them. We go walking, I play golf, but they weren't interested. They didn't want to. Neither did anybody else in the country, to be honest. So I thought, well, I'm going to do this. I've got to do this. So I applied to take over a small single-handed practice, which is where I met your dad. And I set up a patient participation group, formed a friendly, and I have to emphasize that word friendly. You've mentioned relationship, Clarinda. It was a relationship. It was a friendly relationship. It's only I'm looking back after 20, 30 years and realize, well, was it wrong to be friends with the patients in that way? Well, it was necessary. Otherwise, I don't think we'd have crossed the boundaries. And I think that's really important. Friendly, informed and supportive patients. I had 3,000 patients. Caitlin's dad was one of them. Brilliant people. There's all sorts of people who've got all sorts of skill. Artists, musicians, a theatre director. They actually came to the practice to try and teach the patients to behave differently. And I think that is medicine. That's health as it's not just doctors and scientists. Anyway, together we planned, commissioned and built a patient-centred medical centre, which was designed specifically to improve patient autonomy, engagement, partnership, health-seeking behaviour and health literacy. The practice included an information room with a touchscreen information kiosk on which patients could access information about diseases, care pathways, and medications, and this was run by the patients. And my mother paid for that because the health service was certainly not going to pay for it. They did pay for the computer, but they weren't going to pay for the information room. My mother paid for that. And George, my son, said, we didn't have any holidays for 2 years, Dad. When you build a medical centre, he doesn't grumble about it quite so much now. Well, we didn't. We couldn't afford it. I and staff use read codes, and these are codes for an international classification of diseases and SNOMED. They're very, very, very important because they're very specific. So I don't know, Caitlin, I'm completely out of date on cystic fibrosis, but there may be different varieties or different classifications of some sort. If you get on the wrong classification, you're going to get the wrong treatment. But they're very useful, the codes, because once we gave people their own data, we could use those codes and put it into a pictorial record, which actually automatically showed you with pictures. This was a respiratory problem, a gastroenteritis. It was wonderful. It was really good. We offered it to the health service and they didn't understand it and they couldn't use it. So we used these codes with their text to extract patient records from the EHR system onto compact discs, which we gave to fully informed and consented patients. We didn't give anybody the records unless we'd explained to them the risks and benefits. The patients also created a wonderful pictorial template on which to display the data, which I've discussed already, using the 20 main international classification disease categories. And I imagine for both of you, there's probably areas of your disease which affect different systems of your body. Think about diabetes, for instance. It affects your kidneys, your brain. This was the equivalent of a memory palace to aid patients' memory and understanding and to allow patients to study their records and access information that would explain and interpret the records for them into their own time so they could create their own understanding, which would be different to the doctors. But the more information they have, the more time they've learned, the closer they got to the doctors or the nurses or even beyond it. The practice completed the first NHS electronic record development pilot with Oxford University to put the records online. That was a big thing because we were the first people to put patients' records online. It was weird in 2000. You just didn't do that. And also we let patients access their records. And they said, oh, you sort out the consent, will you? Which I've got a very good friend in a very large law firm in Leeds. And they did the work for us to get a proper legal informed consent contract. That's going to be ongoing for the next 20 years across the world. You have to have a dynamic consent process, I think, because you change your mind as you get older or as disease goes on. The practice, we stopped giving copies of notes to patients a few years later, believing that online access would occur soon, and it didn't. It took 20 years. I wish we'd carried on doing it, to be honest. But I was busy. I had 3,000 patients, I had 2 children, and I was chairman of the mini rugby at the rugby club. That's life. As John Lennon said, life is what happens to you when you're making your plans.
Just listening to that, it's crazy to think how early on you were talking about sharing records and getting things online and on computer systems when actually, as Clarinda was saying, a lot of places in the world and even the UK took a while to kind of get that kind of system digitized. It's incredible how much of a pioneer you were in this space.
Yeah.
And
I just want to
Go on.
add something here. So in our last episode, we interviewed a rare disease patient advocate, and one thing that we took away from that was how it just takes one person to have the drive and the willingness to say that something's got to change. And then even if you don't have the expertise, you connect with experts, you find them, you get yourself into those rooms where you can have those conversations. And it's fascinating to me that you did this way back in 2000 when the term electronic health records is only now like a mainstream term. You made it a thing 20 plus years ago. That is incredible.
But I would just pursue that a little bit to say that what you two are doing is not dissimilar. I think not just patients. And I love what you said. It is true. I've been to all sorts of people and places. You're not the expert in those things, but you just try and nobble them and think, have you thought about doing this? It's good fun. I mean, I'm nearly 75 now. I wouldn't call it a game because people think a game isn't serious. It's a wonderful puzzle and it's got real people in it. And it's a bit like a game of chess. Anyway, go on. What's next?
No, that was a very nice tangent. So thank you guys for that. So I guess one thing that I found really interesting when we started talking again was actually your involvement in the Harold Shipman case. So for people who don't know, Harold Shipman is a very prolific English serial killer, essentially, who was a general practitioner who is actually from where I grew up and where you practiced. And I wondered actually, I know that you have a very actually personal experience with that case and what happened. And I wondered if you could tell us a little bit about that and I guess any motivation that gave you to push forward with giving patients access to their records.
Yeah, there's been 2 large events which have pushed forward during my time. I started in 1993 to build a medical centre. In 1996, we built it and we started working with your dad and other people to do this. And a little bit in the back of my mind was I wanted patients to be able to see the records because I forget things. And so if somebody can see the records, they can say, hey, have you done this, Dr. Fitton? And I love that. So that was a safety issue for me. But the main thing for me was to give patients health literacy and agency. So it wasn't trying to catch murderers. That wasn't the reason I was doing it. Dr. Harold Shipman was the chairman of the Parent Teachers Association at my children's school. He was a single-handed practitioner. I was a single-handed practitioner. He had a very good reputation. He was very well known. And at one stage, I was asked to join him by the Central Administrative System of Manchester because they're trying to convert single-handed GPs to work together. In about 1997 or 1998, Dr. Shipman asked me to complete a cremation form. And if a patient's going to be cremated in this country, 3 doctors have to sign a form to say it's suitable because when you cremate somebody, you get rid of the forensic evidence. So the doctor who signs the death certificate, a second doctor, which was me, and then a registrar at the crematorium was another doctor. So it's a pretty strong fail-safe system. So he rang me up, asked me, I can't remember the complete details, but basically it was a youngish 60-year-old woman who he said had a stroke 2 years previously, and she's had another one and he was treating her at home and she died at home. I did complete and sign the cremation form. And about 2 years later, my practice manager said, there's a detective inspector from the police on the phone for you. I thought, oh no, what have I done? But he was part of the investigation investigating Dr. Harold Shipman. And he wanted to know about this cremation form that I'd completed. As time went on over the next 12 to 18 months, investigations went further. He was arrested and put up for trial. And I gave evidence at that trial about what had happened with the patient who died. So he was tried, sent to prison for life or something. And as this was happening, I was giving my patients their records on these discs. I thought, hey, they would have known he'd changed the records because they've got these discs going back a few years. And I was really upset at what he'd done. I'd already doing this National Health Service pilot, and I'd been mentioned in Parliament in 1998 by Charles Pendry, the MP. I did some presentations at the National Patient Safety Association, and I was invited to London, to Westminster Church House, just behind the House of Commons, and I took 6 patients down. We've been teaching patients how to teach other patients to look after the records and stuff like this. And we presented at a national conference. I presented first, and all 6 patients presented. It's a wonderful thing to do, really. And we got a standing ovation. They did. They deserved it. 6 patients talking, not in a negative way about Shipman, but just talking about what they were doing. And in the audience was the president of the United Kingdom General Medical Council, who's a personal friend of mine. And I arranged for him to come up to Glossop the year afterwards, put on a conference for him. And he said, okay, Richard, you can use the headquarters of the General Medical Council, and we will have a public and professional consultation on writing and write guidance for professionals to share records with patients. Anyhow, we had consultations in London, and over about 2 or 3 years, we got some money, £97,000. And the Royal College of General Practice said they would write the guidance. And I said, oh no, they'll bury it. But they didn't. They wrote a really good report about 17 years ago, and then it sort of moved on from there. I've never said a lot about Shipman because I don't think that's the reason we should be giving people's notes is to stop murderers. I don't think that's the reason. The reason for me giving people notes is it helps them.
So while it's not the reason patients should have access to their records, do you think it kind of did actually give it a boost?
Oh, massively, massively.
Yeah, because the case actually, am I right in thinking he was essentially going to patients and giving them something that would cause them to die, and then just falsely sort of signing that, they died at a natural cause. And it took a really long time, didn't it, for that to become something that people even thought of as suspicious? Because again, back to what we said earlier, almost about kind of the doctor being the one who was in charge and knew best. And obviously in the case of a medical scenario, it was just sort of trusted that nothing untoward was going on. But again, in a less sinister case as well, it does kind of demonstrate how it's beneficial for people to actually not to question their doctors, but to also get involved in that process and look at things and make sure that everything makes sense, that nothing's been forgotten, that there's nothing mysterious or suspicious. Again, not that that's the key reason that people should have it, but if they had, it might have sort of caught those things earlier, and also, from a safety perspective in a less sinister way as well.
Yeah, I think that's absolutely right. And actually, the whole process should be like that all the time. In fact, Caroline, my daughter, helped me do the Department of Health copying letters to patients working group. And we actually gave patients their records. There's a paper published on it. And we asked them 2 things. Can you tell us what's missing or what's wrong in your notes? And what's in the notes would you not want to be shared with anybody else? That personal sensitive data. And other studies have shown that 20 to 30% of notes have got errors and got omissions in them. The air industry wouldn't accept that. You wouldn't know 20, 30% of your planes have got something. You wouldn't accept it. I didn't want things to go wrong with my patients. So if you could find something wrong in the notes, brilliant. It means I'm less likely to get sued, but you're less likely to be unhappy with me. And what we found, patients, when you say, look, have a look at the records, see if they're all right, learn from them. If there's anything wrong, let me know. It changes the relationship. It makes it into more like family or friends or stuff, So I think that as a doctor, if you have 3,000 patients, you've got 2 children at home, you've got a wife that works, you've got to run the practice, do the accounts. You've only got so much time with people, and you're bound to make mistakes. And you know for a fact when somebody leaves, they don't understand what you've told them. You can't examine somebody, take a history, make a complicated diagnosis and explain it to them so they understand in 10 minutes. It's impossible. And you only have 40 minutes a year with each patient, whereas the patient has 565,250 minutes every year. I think it's something like that. It's a bit, I always find that quite helpful. That's the time they've got to use their own critical thinking to increase their understanding and represent themselves better when they go somewhere else. Well, the second big factor that made a difference to the implementation and acceptance of patient access to records is quite funny, I think, that during COVID, patients wanted to be able to access their records so they could travel, get a
Go
vaccination
on
certificate. I
holiday.
thought,
Yeah.
wow, you're not interested in getting your own health right. When you want to go on holiday, I thought, okay. But that really made a big difference. And the NHS app is stunning, absolutely stunning.
I think that, of course, while a serial killer is obviously an exception, and that's not, like both of you said, the reason that this is important, malpractice is clearly a more common scenario, whether that's intentional or unintentional, either way, even in error. That is a very good reason for records to exist. And I'm sure that in many, many, many malpractice cases, records don't exist or are not well documented, not well shared with the patients. And I think you've already spoken substantially about the benefits of the records existing and being shared, the value of that in shared decision making, in patients understanding their own health and taking responsibility for it and feeling like they own that space in the room. We've had conversations on shared decision making before, and the sense that we've gotten is that some doctors almost feel sense of insecurity or feel threatened if a patient knows too much or asks too many questions. I love your attitude where you've completely been open to patients pointing out if you've forgotten something or patients asking you, did you get that right? And your sense of partnership that you've been so open to from the beginning. And I think that that's just such a wonderful way for those healthcare relationships to be nurtured and for them to be productive.
Thank you very much for saying those few complimentary things about what I've done. There's another little axiom which Dr. Arma Hanan and I have used, which is that we delegate information and literacy and agency to patients, but we do not abdicate responsibility, if you know what I mean. And I think that's really important. And I'm a bit sad, but I'm sure some doctors will do that. They'll abdicate responsibility and they think it was your fault, you didn't do it. And that really gets me cross. And we mustn't let that happen because still it's my responsibility. I hold the strings of referrals and everything else and the guidance. And yes, I want you to help me make a decision, but I still accept responsibility. It is my problem if something goes wrong.
Yeah. So I'd like to move on to talking about some of the barriers in scenarios where the records are not being captured systematically in countries, in settings where they are not. What are some of those barriers? And in settings where they are being captured but not necessarily used effectively, what are the barriers in that case as well?
30, 40 years ago, when we were discussing these things, one of the statements was that the soft stuff is the hard stuff. And Arma and I go to meetings with very nice people, IT professionals and ladies and gentlemen in suits. And we say they've got all the gear, but no idea. And so they deal with the technology, but they don't deal with the human side of it, the society side of it, the family side of it. So, and I think it was because my wife was an anthropologist and information scientist, I realized that I had to do the soft stuff, which was develop a different type of relationship, a partnership, if you like, and sometimes a relationship in which the patient knew more than I did. We'd work on that together. That is happening inadvertently through Google and all the search engines and things. And over the years, I've heard people saying patients shouldn't bring lists of stuff in them. I completely disagree with that. I mean, I think, great, they've been doing a bit of work. They're trying to find out what's wrong. That's brilliant. And I've got a better chance of actually producing some form of understanding which we can both work with, which might produce a better outcome. So YouTube and Google and Facebook and TikTok, everything else, that's all come along and that's making it happen much more quickly. The technology, I know that's another end of the category once you've got digital records, although, as you said, in your country, people are still using paper records. But you've said yourself that you've got copies of your paper information, which you keep yourself at home. You're unusual, but you're brilliant. That's what you should be doing. I imagine Caitlin's done the same thing. And that's possible with paper records. Now, when I joined my practice in 1979, I had two older partners, lovely people, and they knew what a computer was, but didn't want to use one. So once the older partner left, and then the next partner was going to go, we got a computer. And then we started to install it and to use it. Well, there's a big problem here. There's lots of problems. Two problems. One is you've got to work out how to record stuff as a doctor when you're seeing patients. You have to learn how to type. You have to do it in a different way. It interferes with a normal consultation. And the whole practice has to do that. The second one, and it is a big one, and this is why we're talking 30, 40 years, is you have two systems. You have a digital system and you've got a paper system as well. So you're now running two systems, which, it ain't good news. So there's that. And then there's the costs to the technology. So there's the soft stuff, the changing from paper to digital, which takes 30 to 40 years. I think you can't suddenly do it because you've got 70 years note, like the notes you keep at home, Clarinda. And then there's the costs and the technology. And I mean, in 2000, we were the first people, I think, in the health service to actually put data on the NHS network. And now it goes into the cloud. It's in Amazon. Your records are in Amazon,
Wow.
Kate. I don't know if you know that, but they're stored in Amazon warehouse.
Interesting. Wish I didn't know that, actually.
But I suppose another one, a fourth one, is literacy. People are becoming much more digital literate. This is completely different to it was in 1993 when I took over the practice. People are now health literate. They do understand about privacy. They do understand about security codes. But if I was to be invited to go and help people in India, I'd think, well, this is a 30-year project. You're not going to do it tomorrow. But there are some other issues, which is about how much energy it takes for data warehouses, rare earth elements and things like that.
The other thing that I would just add, thinking about it as well, is just, we're not talking about one practice and getting everything up onto a cloud. Quite often there's a health system, whether it's like a national level. I know in the UK we do have regions and everything, but in essence, the NHS is a national sort of system.
Yeah.
And it's trying to implement that across every single practice across the country and getting that system updated and changed. And whether this is true or not is debatable maybe, but there is kind of always that talk about the NHS that it's always kind of behind technology in those ways, because how do you update a system? Well, that'll take forever, and then you'll need to train people how to use it when they're used to an old system. How do you make that happen and implement it at a nationwide level? And in the meantime, allow people to be treated and for hospitals to keep on running in one go. That's a huge systematic level change that needs to happen for it to be something that really works, especially when, like Clarinda was talking about earlier, moving between different doctors, or even when I moved house up to a completely different part of the UK, how do all of my records that had been in one hospital for 18 years then move over so that it can see them, and then move again when I move back? And then how does that hospital specialized center data move to my GP so they know what's going on? And I can tell you right now that still isn't working now. Even that simple sort of email it to the GP so they have my results, it's not clicking, it's not automated, it's more admin. And it's admin for me as well, because I have to keep explaining that they need to email that and then they need to look at it. But it's also admin for the healthcare system to have to look up these things as well, because it's not all centralized or automated like anything else in our lives is at the moment. My calendar's connected to my Zoom or my Teams, which is connected to my phone, but my GP and my hospital can't talk to each other properly. So it feels like it shouldn't be complicated, but I think that kind of healthcare system level change is really difficult for all of the reasons that you mentioned, but also just to change a whole system that's kind of been set up.
I also think that, so for example, in India, one huge challenge at a policy level would be that the Ministry of Health is one ministry and the Ministry of Information Technology is a whole other ministry, and they both have completely independent portfolios. This is something that needs both to decide in their budget and in their 5-year, 10-year, 15-year, 20-year plans that this is something of priority, of equal priority for both completely independent ministries, and something that they're going to work on together. Policy level implications of that, just deciding that in the first place, and then the rollout, the implementation for a country like India at that scale, with the disparity in economics in rural urban situations, all of it, it's very, very complex.
I mean, I've been very interested in scientific development and evolution. I read a lot of technological history, the history of agriculture and the history of transport and the history of telecommunication. And I know it takes a long time for things to change. And if we're going to get there, and I must say, I don't think we will, but I shall keep hammering away because it makes me feel good. There will be some global solutions, just like you have a global telephone system. So about records, when you'd ask what records are, they include your identity and they include your contact details. And there's some privacy issues about that, who you want to have that and who you don't want to have it. But the privacy lobby in this country, which often gets in the way, is ridiculous. Because if you're so private, nobody knows who you are, you can't be treated for anything. So if you think you had a little baby that was born and nobody knew who it was, it just died, full stop. I've been selfish or self-interested in concentrating globally. Can you imagine how dead chuffed I was to be invited to go to the World Health Organization and I went to the United Nations World Data Forum in China in the same year to present about this, to say, look, I think we need some global standards of health data governance. And those global standards need transparency. We need to be able to see the data that's being processed about us, and we need to be able to see the financial legal contracts under which it's being processed so we can get some sort of balance. That's a long way down in the future. Well, it's not a long way in the future in this country because that's what's happening. And two friends of mine gave evidence to an all-party select committee on artificial intelligence and health about 10 years ago. And we were discussing exactly this issue. What's the commercial case for processing personal health data? If you're a bit of a radical political loony like me, it's not all that dissimilar to petrol or coal or steam or anything else. There will be a commercial model for it. I'm not into that at all whatsoever. I've never been paid for what I do. And my family probably paid a huge amount of money for me to do what I do, but I quite enjoy doing it. So there will be some commercial global solutions. You and I are both wearing glasses. Nobody was wearing glasses 600, 700. Well, there were a few people had sort of glasses, but not many people did. And there'll be a question of whether we can afford it globally. And of course, the third world countries will be left behind all the time. So it'll be 20 to 30 years, I think, before and if it happens in India. The soft stuff is good stuff. So what you're doing on your desk, on your table, is brilliant. And that's the soft stuff. And it's to get doctors to say, look, give your patients as much information as you can. The evidence is that people who have access to the records comply better with treatment. So they take the treatment better, or they don't take it if they don't need it. They attend hospitals less and they attend accidents and emergencies because they know what's going on. So I'm an optimist and I am a pessimist.
This conversation has been really interesting, and I am absolutely sure that we could speak for the next 3 hours on this topic. But, we've spoken a lot about the past and how electronic health records have come to be and why they're so beneficial and why it hasn't yet maybe become the norm and all those barriers to implementing that across the world. I wondered if you could tell me about, and you've already sort of started to touch on this, but are there any initiatives at the moment ongoing that are looking to improve how health records are being captured, shared, or used to improve patient care, either locally or globally?
I was going to have a cup of coffee with one of a practice manager who manages a practice in Stockport. I just wanted to verify what's actually happening in British general practices. And there's an awful lot going on. It's changing. Glossop used to have 4 banks and 4 bank managers. It doesn't have any banks now, does it? I don't think it does. And it doesn't have any cashiers. You don't take money in anymore. So there's a nice example of how things change. If you go to Manor House Surgery in Glossop, which is where my doctor is, Clarinda, you don't ring up for an appointment. You fill in an online form and they look at it and then they say whether you can have an appointment or not. When I first started, only doctors wrote in the notes. And then once we got computers, the nurses started writing in the notes. So everybody writes in the notes now, and the receptionist writes in the notes, and everything that's done is actually recorded in the notes. So that's happening very, very quickly. It produces an immense amount of data. Now, you're not in that position in India, but those things are happening. Something else that's happened, which is absolutely enormous, is messaging. Messaging used to be very expensive. Now it's linked to patient records. We've got 66 million people who have got their address, their messaging details, and we can message them in 2 seconds. Everybody in the country, if we want, we can message them. That's happening. and people can actually message back. It's very complicated. But as I've been trying to write this stuff for the World Medical Journal and a little bit just before this interview, I've been looking at those things. And I think my male time interested in technology and history just makes you realize, I mean, for instance, if you, Clarinda, had been in wherever you live in India 5,000 years ago, you wouldn't have had a car and you wouldn't have had anything with wheels. You'd have been walking, or you'd been on a donkey or on the back of an ox or something like that to move around. Things have moved on since then, and in this country too. So I don't know, just fact, we're covered by ice probably then, so we wouldn't be doing anything. So things are moving on very, very quickly. And part of what's happening is that traditional roles of people are being taken over, and it's like shopping. You buy something on Amazon, you don't go into a shop anymore. It's difficult to find a shop anywhere now. And I think the good news about that is that people are becoming technically very savvy. I think they're getting used to it, and that will be happening everywhere. And those changes have happened far more rapidly in the commercial sector than they have in the health sector. And there's a lot of reasons for that. Conservatism is quite a good thing because it means you don't make any mistakes, but you do something. I was the first person to do this, and I got in a lot of trouble. I was disciplined by the local doctors, but I'm still incredibly cross about it. I won't go into the detail. I'm still very angry. They disciplined me for giving patients their records. I'm still cross about it, but because it's never been done before. Well, so I think those sort of reservations are good. Another sad thing is that when doctors start seeing their own records, they think, oh, this is a good idea. And then eventually think, oh, I'll let my patients see their records too. So I love that sort of stuff. I'm very interested in the development of ideas and systems.
I also wanted to clarify that, I mean, a lot of what you said, for example, in some practices, every single step of the journey is online already.
Yeah.
That does exist. So I live in Mumbai, and that does exist in some practices here.
Yeah.
Every step of the journey is completely online. The doctor is using an iPad throughout the consultation. I'm getting an SMS or a WhatsApp text or remind me about my appointment. Everything's online. So that is fascinating, right? Because I get to see both ends of the spectrum right where I'm sitting. I get to see the promise of what's possible and also how much ground there is to cover. But the fact that that is possible. So that's quite interesting.
Yeah, and I think, as I said before, that one of the big factors was that the drive must come from the bottom. It's not the government, it's people who will want to have their own data. So we want it. We want to help you. We want to work together. And that has certainly changed a lot. But I haven't pushed the agenda of this being to stop doctors murdering patients. It's a really not a good way to go about to sell something. But I think that is really good news. So the idea for me that all patients will actually have their own records or access to all their own lifelong records, which they can pass on to their descendants on their mobile phones or somewhere else, that's a really sexy idea for me, because that really makes the difference. Because you go and see a doctor in a hospital, they go and do the work, they go home, they feed the kids, they go out for a drink in the evening, or they go and see a film or something. That's what they're doing. That's what we all do. But if the patient has still got hold of that stuff, they're not going out for a drink on Saturday night because they've got orchitis or they've got meningitis. I think it won't happen in my time, but if we're still around, because we make such a mess of the planet at the moment, that will be what people get used to, is that actually the family or their proxy, they hold all the keys to all the different records, and you can go anywhere you want, and it's your responsibility. If you're bright enough. If you're not, you're 12 years old or 10 years old, or you've got dementia, society has got legal ways already to let somebody else manage it for you. I think that's the way it's probably going to go. And just to make Caitlin feel even better, it was your dad, God bless him, who actually took the data, put it on disk in a way you've not met him, Clarinda. You've got to be to know what he's like. So this is what you do, Richard. That's what we did. And that was really exciting. But I think that's a global human thing, that it's a balance of, do we trust each other? My wife said, love doesn't exist, Richard. It's just reciprocal altruism. I don't believe that. But you can only love so many people. But there is a system of reciprocal altruism. Whether we'll ever get there as a human race or not with this, I'm not too sure. Tedros Ghebreyesus is the Director General of the World Health Organization, and I followed the press briefings during COVID. They were marvelous, those people. They had all the problems in the world. But at one stage, he said there's the 3 letter C's we could manage this. There's collaboration, which is what always makes me feel good. There's competition and there's conflict. And at the moment, the world's going into competition and conflict. I love collaborating. It makes me feel good. There's something in my genes or my serotonin or pituitary. I like collaborating. If I'm not collaborating, I feel ill. But whether human beings will collaborate enough or not to do it, whether the large tech companies will actually invest time, their money, their technology in something that benefits everybody or just themselves, I'm a bit pessimistic about that. But I don't know. It makes me feel good trying to do something about it.
That was a really, really great note to actually almost end on, because we're nearly at time already and I can't quite believe it. So I guess to finish this really fantastic conversation, what would your advice be to healthcare professionals who want to better partner with patients to improve their overall care?
Well, I can honestly say that spending some time with yourself and Clarinda over the last few weeks has really helped crystallize an answer to that question, partly stimulated by what you're doing and what you're trying to do. And it's very simple for me, but I would suggest to professionals all over the world that you find patients that you like and that you work with. And I think that's important. I think you have to like them. People will say, oh, it's not fair doing that, but don't ask me why, but it works. People you like and you work with, and you invite them to join you in work groups to discuss, design, and improve patient overall care. And I would add one more thing. I would produce with those patients a newsletter once or twice a year and distribute it to those people within your care. That's what I would say. As far as I understand it, to some extent, not just patients, that's something that's great that you're doing. And one final thing on that, when I went to Leeds, I spoke to somebody from the National Institute of Clinical Excellence, but I told them about what I've been doing. I told them about what you're doing as well. And the National Institute of Clinical Excellence now has a policy that they won't have any new group, in principle, any new group looking at any new drug or make it without having at least 2 patients on it. And I think that's brilliant. Absolutely brilliant. Yeah.
Thank you so much, Richard. I've really enjoyed every bit of this conversation. I think when Caitlin first told me, you know what, I want to bring my childhood GP onto this podcast, I was like, huh? Oh, that's not usually how we go about this. It's that as I got to know you, I mean, we've been exchanging emails for a while now. I could not imagine anyone better. And it's just amazing to think that someone from a little town has achieved all these great things. And it's been an honor and a pleasure talking to you today. And thank you for all the lovely stories, the insights, and we have so much to take away from this.
No, thank you. I've really enjoyed it. And I could have wept when Caitlin said the nice things a while ago in an email to me about when we were helping with a family. I think what you've just said, I mean, you have your own lives to lead. But if you want to use the example of us in a small practice, you two are in the same place. And obviously, life, as John Lennon said, is what happens when you're making your plans. But what you're doing is really important. And I'm thrilled to bits that you're going to be interviewed. It's going to be the World Medical Journal. I think if you want the example of speaking to the right people at the right place at the right time, I've given you 2 examples, COVID and Shipman. And you just have to be optimistic. And as I said, they have the traffic lights there, red, amber, green. And most of the time it's red. Occasionally it's amber and very rarely it's green. That's where it goes.
Thank you.
Okay, well, thanks very much.
So, Clarinda, that was a really fantastic and enlightening conversation that we've just had with Richard. I wondered if you could share with me what your key thoughts or takeaways were from that discussion.
It was a really different kind of conversation, Caitlin. Thanks for bringing Richard on board. I think that for me, what was interesting about this conversation was that it kind of builds on conversations we've had about shared decision making, but takes it a couple of levels deeper, because records substantiate shared decision making with an actual piece of paper that patients can go back to and make sense of. It can be quite difficult for patients to absorb everything that they hear in a consulting room all at one go. But having a copy of the notes allows them that space and time to review or make their own notes, come back with questions, remind the physician if they've missed something, And that is what partnership is about. And it very much requires the physician to have an attitude of partnership. Like we heard from Richard, he's actually quite thrilled when patients come back and say, have you forgotten this? Which not all physicians are comfortable with. But access to records just gives patients that kind of empowerment to feel like partners.
Absolutely. And I think the second level of that is just about safety as well.
Sure.
Because, one of the things that stuck with me is Richard said he deals with a patient for maybe 10, 15 minutes twice a year, maybe,
Right.
whereas a patient is living their disease every single day. So there will be things that are just missed in that consultation or not noted down, for example. And actually, if a patient has access to their own records, they can spot those errors or mistakes. And that means that they can then make sure that they're corrected and on record from a safety perspective. Because if you're then prescribed a new drug and the system is supposed to alert you to any kind of drug reactions, but your other drug isn't on the system, that can really cause safety issues. And likewise, if you're on holiday and you end up in a hospital and it's not your usual one and there's not a clear record being sent across, they could miss something about your medical history that's really important. So from a safety perspective, and also even from a malpractice perspective, we heard the most extreme example of Harold Shipman in this conversation. But what you want to be able to do is make sure that you have as much information as data as possible to be making informed decisions, but also to be able to protect yourself and ensure that any doctor that you're interacting with understands your medical history.
Yeah, I think that that's a really important point. But what is really essential for that in practice is the transferability of records across systems. And for that, they need to be digitized. And that's a whole other conversation, though, which is about equity and about standardization globally, which we are not ready to have. I think that even within countries, we're at all very, very different places across practices, and then across countries, across regions, the way that health data is captured, shared, is extremely diverse at the moment. I gave examples of how, in India, it could vary from absolute paper records or like patients going away with nothing to complete end-to-end digitization. So I think that there's a long way to go. Standardization is, I think, the goal, and digitization, complete access, continuity in terms of transferability between practices where patients can go even on a holiday to a different country, ideally, and be able to access their records on the cloud in some global system. That should be, I think, the absolute vision. There is a long way to go, but I think it was a very hopeful thing to see the kind of remarkable work Richard has done for the UK as pretty much a single GP in a tiny practice. And that gives a lot of hope for what's possible and what the future could look like.
Absolutely. And I've seen it evolve really drastically over the past 10 years or so in the UK. And while it's still not fully there and fully integrated, and certainly it's not everywhere, actually a large part of the evolution I've seen is because I moved to London, and that's sort of ahead of the game, maybe in terms of the digitization. But it is really promising that it can happen, and it is happening. And it's just making sure that it's consistent and standardized. And I think we're absolutely going in the right direction.
Absolutely. Thanks so much for listening. This has been Not Just Patients with our guest, Dr. Richard Fitton, and your hosts, Caitlin Rich and Clarinda.